Good evening. On behalf of Ceylon College of Physicians, I'm Himanta Athukorla, and welcome to an exciting third episode of the series of webinars titled Collegia Unitum Scientia, Colleges United in Science.
A very good evening to all of you who are joining this webinar. I'm Arosha Disanayake, President of the Ceylon College of Physicians. Welcome to our third program under the project called Colleges United in Science, Collegia Unitum Scientia. Now, traditionally, the College of Physicians has been collaborating very closely with the sister physician colleges like cardiology and urology. And then this year, we are trying to expand our horizons and collaborate closely with experts from non-physician colleges also, so that we all benefit in this exercise. The first in this series was Dr. Satish Punasinghe, who was the president of the College of Surgeons. The second was again from a leading light in psychiatry, Professor Raveen Hangwella. And this evening, we have the third in this program with Dr. Harindu Vijayasinghe on sports medicine. Now, Harindu's specialty is, of course, rheumatology, which is a sister college, but today's lecture is on something slightly different on sports medicine. So, which is again, we are collaborating with members of the Association of Sports Medicine in Sri Lanka. The idea is that we become more rounded as physicians, that we deal better with some of the everyday problems related to sports medicine that we see. We know what we can possibly manage, and we will know whom we need to refer and what stage to refer, as well as where they should be referred and what can be done for them. So that's the outline. Now, I will leave the formal introduction of Harindu to Himanta. And then, of course, on a very personal note, I have had the pleasure of being with Harindu, serving in the Board of Sports Medicine for about 3 years, when Harindu was the secretary. And I really must say that Harindu single-handedly did so much of work to establish the sports medicine program, and that program is where it is today, to a large extent through the enormous commitment and dedication of Harindu during the initial stages where the program was set up. So I had a ringside view of how Harindu worked, and I have nothing but admiration for his commitment, his foresight, and his ability to organize things. So, I mean, Harindu is somebody exceptional. He knows sports medicine as well as anyone in this country. And may I now invite Himanta. Now, Himanta is the college council member who is coordinating this entire Colleges United in Science program. Himanta keeps lining up brilliant people for these talks. So thank you, Himanta, for your excellent work and commitment to the CCP. So Himanta, it will be wonderful if you can take over now, formally introduce Harindu with all his achievements, and then invite Harindu to do the lecture as well as handle the Q&A session. Thank you very much. Over to you, Harindu. To Himanta. Thank you.
Thank you, Prof. Arosha. So I would like to briefly introduce Harindu. Now, Dr. Harindu Vijayasinghe is a consultant in rheumatology and rehabilitation and a specialist in sports medicine. He is a product of Royal College, in which he captained Royal College first 15 rugby team in 1992. He worked as a sports medicine fellow at New South Wales Institute of Sports Medicine and worked under Professor Siri Kannangara, a famous Australian rheumatologist and sports doctor. He was a doctor for Sri Lanka cricket since 2011. And he was the president of Sri Lanka Sports Medicine Association from 2014 to 2018. And he is the former secretary of the Board of Studies in Sports Medicine at PGIM. So today's fast-paced lecture by Harindu is titled Sports Medicine in Clinical Practice. Now, please note that questions will be discussed at the end of the speech, and you could type your questions in the Q&A box at the bottom of the screen. Over to you, Harindu.
Thank you, Himanta, and thank you, Arosha, for those kind introductions. So today, I will be speaking about sports medicine in clinical practice. Mainly, I'd like to focus on a few things which are important in your clinical practice. Also, certain things which will help you to prescribe exercises for yourself and for others to improve their health. So sports medicine in clinical practice has many areas. One of the main is injury management and rehabilitation of athletes, people like Angelo Matthews. Prevention of injuries. So you prevent injuries occurring in athletes. Prescribing exercises for populations and patients. So as I was telling, three main areas in sports medicine: injury management and rehabilitation, injury prevention, and exercise prescription. And these are the three areas I'll be mainly covering in the lecture. I'll briefly mention the other ones like nutrition and hydration, where we give athletes proper nutrition to improve their performance and get them to hydrate properly so that we get the maximum performance. Sports psychology, it's a very important area, not only for athletes, for anyone, because it just tells you how to succeed and how to be happy also. This book I would recommend to anyone, How Champions Think by Bob Rotella. It's worth reading, and I would recommend to buy it and read this. Next is biomechanics and exercise physiology. Now, this is sometimes done by sports scientists, but our sports doctors also get involved in using these tracking devices, special camera systems to analyze motion, like they did to Clear Muralidharan when he was accused of bending his arm when bowling. Well, now we have these massive events like marathons, World Cups, even Olympics, and sports doctors are involved there to ensure the safety of the sports people there in case they get some emergency, so that things like ambulances, defibrillators are on hand. And also they have to look at spectators, because sometimes spectators get medical problems in these events, and to look after them in case they get any problems also. So you have to organize all the facilities needed at events and also to ensure the safety of the participants. A very important area is anti-doping or catching people who use illegal banned substances. So as sports doctors are involved in this. As physicians, you should know that you should not prescribe athletes with these substances. So you know that we have a lot of problems. Upul Taranga, if you can remember, he took alternative medicine and got caught for doping. Kusal Janit unfortunately had a false positive sample. You can remember Susantika's controversy. So we have had our fair share of doping scandals. So remember, things like beta-2 agonists are banned. You can use inhalers, but there are certain doses that you have to keep under. Diuretics, you remember Shane Warne, the late and great Shane Warne, told that he took a diuretic to lose weight, but diuretics are banned because they can mask agents. And even drugs like our steroids, they are banned inside competition. You can use it out of competition. However, you have to see that it clears off. The steroids mean things like prednisolone, not the anabolic steroids, which are banned. So as doctors, you have to know some of these drugs which you can give and you can't give to athletes, because you can get caught by giving someone, and we have a doping act, which is legal legislation now. If you're not sure of a drug, whether it's banned or not, I suggest to go to this website, globaldr.com. And if you go into the site and you can select either any of these countries, Sri Lanka doesn't have an isolated site, so you can go in and enter the drug, and it tells you whether it's banned, whether you can use it. So I recommend anyone. And if you need to give an athlete a banned substance, you need to fill up these therapeutic exemption forms. So we have a Sri Lanka Anti-Doping Association, which is very good. You can contact them, or our sports medicine doctors are available at clinics all over the island, and you can ensure their help. But please see that you have the diagnosis, treatments, everything documented properly before you fill these TUEs. So going to the main areas of our lecture. So three main areas, and I'll start with injury management and rehabilitation. Now you can see sportsmen can get a large amount of injuries. Now this is Johnny Wilkinson, 2003 World Cup winner in rugby for England. And you can see the number of injuries he had in his career. And they range from mild things like ligament strains to severe things like even lacerated kidneys. He has got a lacerated kidney. So you can get life-threatening things. He has had neck surgery, So you can have life-threatening injuries or events or musculoskeletal events when you consider sports injuries. You have to know a little bit about fatal sports injuries, things like cervical spine injuries. So doctors have to know how to immobilize and transfer someone with a suspected cervical spine injury, how to diagnose the signs and symptoms of a concussion. And you have to know to refer somebody with a concussion either to a neurologist or a sports doctor, because someone who has had a concussion shouldn't be playing at least for a week or two, and they should be rested. People can get heat stroke. So if somebody comes after playing in the hot sun with a lot of body pain, please keep in mind heat stroke, because heat stroke can end up with multiple organ failure if not picked up and treated properly. And sudden cardiac deaths. Now, these sudden cardiac deaths do occur rarely in young sportsmen. They occur to multiple reasons, like these cardiomyopathies, like hypertrophic cardiomyopathy, these channelopathies, and various causes. These are sometimes very difficult to pick, but we're very happy to say in Sri Lanka, we have a very good program where school children who are doing endurance events or contact sports, they have to undergo a pre-participation screening, and this is done by our sports doctors in clinics island-wide, where they will check ECGs, give a questionnaire, and do a small stress test and check whether these players have any of these things. And so some are picked up like that. In elderly populations, sudden cardiac death usually occurs due to cardiovascular events. So when prescribing people to go and do exercise, please see that their cardiovascular risk factors are well controlled. And if you have any suspicion, refer to a cardiologist to assess them prior to exercising. But fortunately, the majority are non-fatal musculoskeletal injuries. Musculoskeletal injuries can be pathologies in any of the organs in a joint. Now, you know, a joint is a place where two bones meet, like the knee, where you have the femur, the tibia, and the kneecap, the patella, and you have cartilage in between. You have ligaments which support the joint, and you have muscles and their tendons which give movement. So you can get a pathology in any of these, and it's very important, like clinical medicine, that you do a proper diagnosis. It's not jumping in and treating with your painkillers or applications. You need to have a proper tissue diagnosis in musculoskeletal medicine. Diagnosis, nothing changes. It is history, focused examination, and the relevant investigation, which gives you the diagnosis. And why it's so important, I mean, if you look at a knee, you have to keep in differentials like non-sports related causes like malignancies, like osteosarcomas, infections, inflammatory arthritis, and along with that, things like dislocations, fractures, and sprains and strains. So you have a large differential diagnosis here with many pathologies. So you need to do it, and you need to take a history. Normally, we take the red flag signs. Also, along with that, we take a sequence of events, how the injury occurred, whether there were past injuries, whether there was a swelling immediately, whether there were sounds, clicks, performance. So it's quite a long, extensive history, and some injuries we can diagnose just from the history. Then we do examination. Now, one thing I have to tell all physicians and doctors, joint examinations is something you have to know, because you are going to have to see a neck or a back or a shoulder or a knee someday. You don't have to be a rheumatologist. You're going to get patients. So please know your joint examination. So if you take a knee, we have a lot of tests. Now, these are anterior draw, Lachmans, and pivot. We do to check ACL injuries, then for meniscal. So we do all these tests. And so with the history and examination, we come to a diagnosis, and then we try to pinpoint with imaging. Blood tests we do very rarely, only when we suspect inflammatory events. X-rays are good, but usually they are only good in sports injuries to exclude fractures. Ultrasound scan, remember, it all depends on who does the ultrasound scan, and it's only mainly good for superficial things like Achilles and patella tendons. Nuclear imaging, we don't use it much here. CT scan, again, it's good to delineate fractures and bone pathologies, but remember, a lot of radiation. As sports doctors, and especially in elite athletes, we straight away go for MRIs along with X-rays. The simple reason is you can see in this MRI, nearly every single tissue is very well seen and you can grade it. But a word of caution regarding imaging, don't just do imaging and follow up and treat them on imaging findings, because everybody, if you do something like an MRI, shows a little bit of a wear and tear somewhere, and that may not be the actual diagnosis, it might be somewhere else. So be sure that history, examination, and the imaging has to support it. If not, be very careful when you start treating. So once you get the proper diagnosis, it is about treating. Now, for a long time, sports doctors, what these sportsmen and coaches used to do was do doctor shopping until they found a doctor who said either jabs the injection and tells them to play, or gives a drug and tells you can play. However, we do use drugs, we do use injections and surgery. However, our main aim now is not that. Our main aim is to do a proper rehabilitation to ensure that this athlete does not get injured again, and that we improve his performance after doing the rehabilitation. So rehabilitation is the process where we try to get an injured tissue back to what it was before injury. So if, as you know, tissues go through various healing phases, and a damaged tissue heals with a scar, and the scar usually is not 100% like the normal tissue, but our aim is to treat this athlete or even a patient so that he has a very good, strong scar, which is very unlikely to be injured. And we also overcompensate by strengthening muscles around the ligament, around the ligaments or surrounding muscles, so that it compensates for whatever lack of strength in the healed tissue. Now, this rehabilitation process is not only for sportsmen, it's for all our soft tissue injuries that we see in our rheumatological practice, like necks, backs, rotator cuffs, tennis elbows, plantar fasciitis, Achilles, or knee injury. We use a rehabilitation process to get these tissues back to their original status and to prevent the problem from coming again. So this is what we do in musculoskeletal medicine. So we start treatment. So we call the first 48 to 72 hours the golden hour, because after any injury, if you do the golden hour properly, the time to recovery is much quicker. So first thing is to rest it. Ask them not to run on it, not to put a load on it. Then you ice it. So you can ice it in many ways. This is a cryo cuff and a cooler that we use in players. We have motorized ones also, which keeps on circulating cold water around the knee and gives compression. But at home, you can easily do it. Just put some ice in a bag. Remember not to put ice directly. Apply like a light handkerchief or a small towel or even a tissue. Keep the ice. You can buy these ice packs from pharmacies also. You ice for about 15 to 20 minutes. Remember not to exceed this time, because you can get ice burns, and you can do it every 2 to 3 hours even initially for the first 48 hours. And this really brings down the inflammation. Please never do this, right? Never put a foot into an ice bucket or arm. It's a sure way to lose it, because you can get frostbite. So remember not to do this. So with the ice, we put compression. Remember to check for peripheral circulation before you compress, and elevation. So rise, rest, ice, compression, and elevation to get this tissue. And we ask the athlete not to run. Don't put heat in the first 72 hours. Don't massage it. These things are important. And tell the athletes to avoid alcohol. Then we start various modalities like ultrasound treatments. We have our physical therapy modalities done by our trained physiotherapists. Gentle tissue stretchings and manipulations like strippings to get the scar tissue to heal properly. However, our main aim is in getting the tissue back to normal is a principle called overload and hypertrophy. So when you overload a tissue, you stimulate it to hypertrophy to be a stronger tissue than it was before. Now, this was very interestingly first reported in Greek times. So they said that this wrestler called Milo of Croydon, before the Olympic Games used to carry a calf around the field. And as you see the calf turning into a bull, you can see Milo also turning almost into a bull, right? So this is the principle. So if you slowly overload something with weights or with bands or with running, the tissues hypertrophy very gradually. If you overload it too much, it can break, but the gradual overloading is the principle that we use in rehabilitating in the injuries. So one of the most important things we overload and hypertrophy is muscle. Now, muscle has 5 properties which we need. One is muscle activation, how muscles activate in sequence. If I give an example to prevent hamstring injuries, we want to see that your glute muscle fires, your gluteus muscle fires before your hamstring. So it's called glute activation. So we get the muscles to activate in sequence with various exercises. We build up the strength. So strength is how much a muscle can push, like on a squat or a deadlift. Power, how quickly a muscle can implement its power. So how explosive athlete is, and the muscle endurance. So all these characters are important in a proper rehabilitation of an athlete. Then flexibility, you need to get the tissue to be flexible, almost equal to the other side. You need the cardiovascular, as you get injured, you don't train, your fitness drops. And when your fitness drops, you go back after injury, you can get re-injured as you get tired. So we maintain their fitness with run-in drills. Tissues lose their balance. So we have things like Bosu balls to build up proprioception. We do functional exercises like skipping, running, jumping, which mimic movements on the field before they go back to play. And we start sports specific skills. So this is very roughly what sports rehabilitation is. It's a long process. So if I just show a video of an example of a soccer, so we mix several aspects. So you can see they're doing skills, they're doing strength, they're doing balance, all at the same time. So we try to do 2 or 3 at the same time, and the player also doesn't feel. Now he's doing fitness by running, he's doing agility, and again skills. So we try to mix up everything. So here he's doing a jumping. So like this, we develop various rehabilitation programs, and it is monitored. And rehabilitation is a team effort. Physiotherapists, fitness trainers, skill coaches, all of us get together in this process. And you can see it brings out champions after a proper rehab process. This is Dushmantha Chamira. He had many injuries, back and ankles, and he was bowling. He's a champion fast bowler now after undergoing a successful rehabilitation period over a long period. So that is about rehabilitation of injuries. So I'll try to show you a few interesting cases that we've come across during our time. So one, it is knee injury in a fast bowler. Now this bowler had knee pain for about 2 years. He had several injections and surgical procedures. Now this was because MRI was done and it showed a meniscal injury. And this is where I say, don't go only by imaging. And suddenly Sri Lanka Cricket remembered that there was a specialty called rheumatology, and they called us in to see him. And when you saw the player, he had an effusion and it was slightly warm. Now, and we stuck a needle in and we aspirated it. When you aspirate fluid, you can get 3 basic colors. You can get this straw colored fluid, which looks like cream soda, very light color, which you usually see in things like meniscal injuries. This is the normal colored fluid that you see in the knee, but in a minute you get a lot more when you get an injury. Then you get blood, which you see in things like hemarthrosis, when you have fractures or ACL injuries. But in this case, we got this fluid, which is more purulent and suggests the inflammatory process, either an infection or an inflammatory arthritis or a crystal arthritis. His cultures were negative. His immune tests were negative, but he had very high inflammatory markers. So what do you think the diagnosis was? Well, gout. His uric acid was 14. So what had happened was he had been on a very high protein diet to build up muscles, and unfortunately his gout was mistaken for meniscal injury, and he underwent treatment for 2 years, and following our treatment he got better, he returned, and this was a good moment for us. From this moment on, Sri Lanka Cricket said that any surgeries or procedures has to go through our medical board, and we were brought on board to Sri Lanka Cricket. The next case is an unusual bowler, a fabulous bowler, about Lasith, who had a knee injury a few years back. And the problem with his knee injury was Lasith was walking. If you examine the knee was normal. There was absolutely no clinical signs in the knee. And he could bowl a few overs, but then the pain increased. And there was a big controversy, and Sri Lanka cricket and even the media were saying Lasith Malinga was malingering and he didn't want to play for Sri Lanka. So we were asked to inquire into the matter. And what we found out was that it was a stress reaction in the knee. And I was very happy we were featured in Cricinfo. We did many press conferences also regarding the injury. Felt like a celebrity for a few minutes. So this is the injury that he had. It's a stress reaction in the medial malleolus of the femur. Now, a stress reaction is a strange injury. It's a bone injury, which is just before a fracture. And these stress reactions can be very difficult to pick because the clinical examination is normal. They are even more difficult to treat because they are very unpredictable, this thing. So we diagnosed it based on MRI. And his injury kept getting worse over the months. And what happened was even the Mumbai Indians cricket, the medical team also flew in to see him. So we managed him in consultation with an orthopedic surgeon. We never try to manage injuries alone. We always manage with a team because it gives a better outcome. And we thought of initially trying to manage him conservatively. And so we did, this is an offloading knee brace. We did non-weight bearing training and strength training for him to strengthen muscles. We used bone stimulators. We used increased the bone stim. He couldn't tolerate bisphosphonates, so we gave denosumab. And fortunately for us and Lasith, this injury healed over a period, and it took a long time. It took about 12 months, and he didn't need surgery. And Lasith returned to play for Sri Lanka, and he also bowled a final over when Mumbai Indians won the IPL. And the nice Cricinfo article said, creaky knees and all, one of the greatest death bowlers went for the win. So, so this is another successful rehab that we had. The other rehabs that we've been doing a lot in fast bowlers. So if you look at these fast bowlers, when they bowl at landing, they hyperextend the spine and then they flex it and rotate it. So it puts a lot of stress. And fast bowlers, they get a lot of disc problems, facet issues, stress fractures, a lot of back issues. Even batsmen get this. So again, a fast bowler between the ages of 20 to 20, about in his early 20s, he's a right-arm bowler with a left pain in the left lumbar region. Now, when you say that, it immediately rings a bell. There were no radicular features or red flag signs, and his neurological examination was normal. So what's the test you would do next? Well, it's called a Codrod's test. And when you hyperextend the spine, it reproduces the same pain in the bowler. So if it's a right-arm bowler, if it reproduces in the left-arm side, we say it's positive. And it suggests this injury caused pars interarticularis fractures or fractures in the area between the pedicle and the lamina in the spine in this area. It's also seen in gymnasts who do extreme hyperextensions of their spine, and tennis players and some swimmers. So how do you treat these fractures? So very important that you have to first diagnose it properly. So everybody knows the Scotty dog. So you can see a normal neck here. Here you can see the neck. So this is a Scotty dog fracture. This is on a CT. You can see it even more clearly. MRI is the treatment modality that we like because you can pick up this even before it fractures. So that is the MRI appearance. So we use these various modalities. You can use nuclear imaging also. So once you diagnose this as a stress fracture, the treatment is no surgery. Rarely you do need, but most of the 99% of stress fractures can be managed with a rehabilitation program where we strengthen the core. So if you see, this is an Indian fast bowler, you can see how strong his core is. So you strengthen the muscles in the core. So if you look at this is the vertebra, you can see how many muscles are around this. And if you strengthen these muscles really well, we do a rehab program from about 0 to 9 months. The first month is resting. You can, even though these fractures don't heal, you can get these bowlers to bowl at 140 plus, just with a strong core. And I think there's an important message for all clinicians and who treat back injuries. If you can do this for fractures, the same can be done. And this is what we do in our clinical practice for nearly all our patients with back problems like this. You don't need surgeries. You can manage them with core strengthening programs. So the next common injury we see are lower limb muscle injuries. They're very common, and we've seen more than our fair share, I think. So injuries mainly of the hamstrings and the calves are the ones we see along with adductors. And hamstring injuries are one of the most common. Now, the reason is if a muscle crosses two joints, so the hamstring crosses the hip and the knee, they are more prone to get injured. So that's why the hamstring is one muscle, and also it's a muscle which works to decelerate the joint. So we call it an eccentric motion, and muscles who contract in these eccentric motions get injured more. So that's why the hamstring is one of the most common muscles to get injured. So again, I want to present a case, how we guide this hamstring injury treatment, not only by clinical signs, by imaging. So again, a fast bowler developed pain in the posterior thigh on running. So this is a typical thing that will say it's a hamstring, and they had tenderness over the thigh, especially in this area. And this is one test we do. We get them in the prone position and we get them to flex the knee against resistance, and it usually reproduces the pain in the hamstring area. The other thing you can do is like a SLRT, which also reproduces. One differential always to entertain is back pains radiating into the thigh. So you have to differentiate that. So on imaging, this is the biceps femoris. It's a strange muscle. It has two heads, one a proximal head from the usual tuberosity and a distal head. And the muscle is in the middle, the long head. So the injury was here. We call it a myotendinous junction, where the tendon and the muscle meet. And he had an injury in both the tendon and the muscle. And when you have a tendon injury, we know tendon injuries take a longer time to heal. So we do the rehab them. And if you look at this interesting exercise here, this is an eccentric exercise called a Nordic. So we did this rehab, the full rehab for these players. And once you do the rehab, we have a thing called a return to play criteria. We have to make sure the injury is healed. This is something like discharging a patient with sepsis, where you check whether they have no fever, whether the patient feels better, whether the CRP is normal before discharging them home. So something like that. So we make sure that several criteria are met before we get a player to play. So one thing is that the strength is equal. Now this is a handheld dynamometer, and you can measure the strength of the hamstring by doing this test. So we measure it and we see that it's equal to the opposite leg. We see that they're able to do functional exercises. So one functional exercise is a single leg glute bridge that we get them to do. A player should be able to do about 30 on each leg without pain. We get them to do running, jumping, so they should be able to do this. We gradually increase their running, and they should be able to do all their running drills properly. They should be able to do their sporting activity. Again, we gradually increase, but they should be able to bowl a certain number of overs before they come. So normally we go by clinical criteria. However, we have learned in things like hamstrings, you have to go by MRI evidence of tendon healing, because if not, this will happen. If you return someone before the tendon has healed, and you can only check tendon healing by MRI, because they can do nearly all of those things, even with a damaged tendon, but the tendon will give way in an activity, sometimes in matches. And in this athlete, actually the tendon has ruptured, there's a hematoma, and the muscles are all buckling down. So to prevent this, you have to make sure that you have imaging evidence of healing in certain injuries. So that is actually the first part of my lecture about injury management. And I told you the importance of rehabilitation, and we discussed some important, interesting cases. The next thing is, of course, preventing injuries. Now, you wonder why I put iceberg here. Well, prevention of injuries is doing training. This is Virat Kohli, the proper training day in, day out, running. These are Olympic lifts, fielding drills, skills, the more better skilled you are, the less chance you get injured because your muscles work more efficiently and you'll also score more runs. So the crux is that injury prevention just means doing things, and along with this, resting, not making late nights like some of our cricketers have done in the past, eating properly, avoiding things like drinking. So all this. So that's why. So when you see a successful player like Virat lifting a cup, right, or Wanindu Hasaranga, remember there is tons of hard work. So that's why we have shown the iceberg here. And basically, injury prevention also means performance enhancement. And good players like, I think a poster carries the pictures of Mahela and Sangha, those are champions. And because they do these things, they get less injured and also their performance becomes world class. And one important thing, this is actually from a coach and something from sports psychology, everybody wants to win, but it's not that. It is that you are willing to prepare to win and do those things daily that matters. So that's about injury prevention. So the final part of the lecture, and I think the most important part is exercise prescription. So as you can see, man, as the TV got smaller, man has got bigger over the years. And this has led to a lot of problems. So it's estimated that inactivity causes 5 million deaths. This is 2008, but nothing has changed. Every year they say this amount dies due to inactivity, because inactivity has two parts. One is prolonged sitting in the same position. So that's why we encourage people to get up this thing. The other part of inactivity is doing exercises, doing something like walking or running for a certain. So you have to do both exercises and reducing inactivity. And this inactivity causes many diseases like heart disease, diabetes, and even cancers. Now, how much of a risk factor is being inactive? Now, this was proven by this longitudinal study published in the British Journal of Sports Medicine 2009. And they took about 60,000 people, men and women, and low CRF is cardiorespiratory fitness. They measured this cardiorespiratory fitness by a treadmill test. And they measured over this period how much of a risk factor having low cardiorespiratory compares to other risk factors like hypertension, high cholesterol, obesity, and smoking. And I'm sure you'll be shocked by the result. Yes, low cardiorespiratory fitness is the biggest risk factor for death, even above things. So I think for all our clinicians, we measure the blood pressure, we check the sugar, we check the cholesterol, we ask whether they smoke, we measure the weight. But how many of us do ask whether you exercise, which seems to be the biggest risk factor for death? And when you give your statins, your pressure tablets, do you prescribe the most important intervention? Exercise. So remember, exercise is medicine, and it's one of the most important medicine, and it doesn't cost anything and it doesn't have any side effects. So I think all clinicians should be prescribing exercise in their prescriptions, and it will cut down your drug prescription by half if you do exercises properly. And it will save the country a lot of money. So how does exercise actually reduce? Well, there have been a lot of studies done, but the main thing is the more physical fitness. It's like the overload and hypertrophy slide I showed. When you overload your body, when you walk, when you exercise, it causes changes in your body. It starts from changes in how much of oxygen your lungs take in, how it's transported, how much your heart works well, how much your endothelium, even your mitochondria. There are changes in all the organs, and they say your cardiorespiratory fitness changes. Yeah, you can measure it by doing something like a VO2 max, and exercise improves your cardiorespiratory fitness, and that's how it reduces mortality. So doing exercises which improve cardiorespiratory fitness, like walking, running, cycling, things like that, are the most important things in reducing mortality. Number 2 comes exercises which strengthen muscles, like weights or resistance, but that is number 2. So the important message is the most important thing is cardiorespiratory fitness to reduce mortality. The next question was asked was, how much exercise should you do to get a benefit, and how much of a benefit can you get from exercise? Well, again, there was this excellent meta-analysis done, published in 2011 in the Circulation. So they plotted the risk of coronary heart disease against the time duration of exercise and based on the calories. And when, as you see, as you keep increasing how much you exercise you do, how much calories you spend, your mortality risk goes down of dying from coronary heart disease. But you can see at one point, this seems to taper off slightly. So this point is the point at 150 minutes per week of moderate. This is moderate is just walking. And at this point, you get a 14% lower risk of coronary heart disease. If you go to 300 minutes, somewhere around here, you just get 6% more. So based on this, nearly all the exercise guidelines say to do exercise to reduce your mortality, walk at a moderate pace for 30 minutes, 5 days a week for a total of 150 minutes. This is one guideline. Or I prefer 40 minutes, 4 days a week, which also seems will get you the same benefit. You can do the 150 minutes on one day. However, the chance of getting injured is much higher. They call that weekend warriors. So we recommend one of the two. Now, the important thing is you don't have to straight away do this. You can gradually increase it over a period of time. So that's what I normally tell people. Start with 10 minutes every other day and gradually increase. If you have an elderly patient who's unable to do this 30 to 40 minutes continuously, I get them to break it down into 3-4 times a day. You still get a benefit. So in 10-minute blocks, you can do it. However, remember, always more is better. So if you can do more without getting injured or without getting sick, do more. But this is the basic recommendation. And how you check moderate pace, it's very easy. If you can talk while you're doing exercise, if you can maintain a conversation, it's generally considered moderate pace. Or you can check it with heart rate monitors. So this is the basis of guideline, how they have come to the guideline exercise recommendation. This is from the American Heart Association, where they say 30 minutes, 5 days a week for 150 minutes total. Or if you run, because roughly 2 minutes of moderate exercise is equal to 1 minute of strenuous exercise. So if you do 25 minutes, 3 days a week for total of 75 minutes, you get the same benefit. However, you can injure yourself if you're not fit enough. A very interesting, the guideline says for lowering blood pressure and cholesterol, 40 minutes, 3 to 4 days a week. Now, these are all cardiovascular exercises such as walking, cycling, swimming, running. For weight training, they said to add on top of this. So if you do this and you still have time, add weight training in for about 2 days a week. So we normally recommend full body exercises, say about 2 exercises for the leg, few for the arms, and some for the core. If you notice, flexibility is not given here because flexibility, being flexible, does not improve your give you less risk of dying of heart disease, but you can do it. And things like yoga and all give you, they say, give you improved balance. So less chance of falling as you grow older, but you get the same benefit from exercise. So remember, flexibility is not included in this. So the main thing is cardiovascular exercises. And if you have time, resistance exercises or strength training exercises. Now, a few myths about exercising. Now, people exercise to lose weight. Now, I think you should all know the reason you exercise is to reduce your cardiovascular mortality and to live longer. If you want to lose weight, it's about dieting. So you have to throw out all these foods that we all really like to eat. And you have to go on a calorie restricted diet till you lose weight. So I would say get the help of a sports doctor or a good nutritionist and go on that. Because what happens is people walk 2-3 hours a day, they over exercise and they get injured. Especially if they're obese, the risk of injury is higher. And sometimes dietitians actually don't get people to exercise initially to lose weight. They get them on the diet, and only when the weight comes down, they add in exercise, because sometimes exercise stimulates appetite. And about 85% of losing weight comes from your diet. Next is losing belly fat. Now, there are many remedies given to lose belly fat, right? Now, there's one important thing, it's called spot reduction. You can't exercise a part and expect that part to reduce. So if you are doing your crunches or you're bending or the various appliances advertised or rubbing various things, putting various belts, I mean, she didn't look like this by putting this belt on, right? So you have to realize that the only way to lose belly fat is a proper diet with a good exercise program. And that's the only way. For the ladies, one of their biggest problems is reducing the arms. So again, you can't do spot reduction. You can't just do super easy exercises for the arms and your arm doesn't become like that. So she dieted and did a lot of other exercises to come to this level. So don't get caught to this. It's called spot reduction. You can't lose your arm fat by just doing arm exercises. So the other thing is, now when you exercise, you know your benefit, you get a benefit just by doing moderate exercises, say walking, cycling. And as I said earlier, 2 minutes of moderate exercise is equal 1 minute of strenuous. So don't do strenuous exercises like running, like say competitive sports like badminton and all, unless you're fit enough to do it. Yes, if you're fit enough to do it, please do it. For the rest, remember, you can get injured by doing this. So stick to moderate exercises like walking, cycling, and these ellipticals. They're also very good, though they're expensive. So go to gyms and use these. And if you have knee injuries, you can do walking. You can do these exercises, knee and back injuries, especially patients and elderly patients. If you're fit, do the more strenuous ones. But doing these is quite enough to get your cardiovascular mortality down. Next is exercising without injury. Again, high impact exercises like jumping, skipping. Again, if you're fit, do it. If not, you don't need to do it. And if anyone is in, these are called calisthenics. So here you do several body weight motions. And it's a new form of cardiovascular exercise which is done. So you do this in circuits. They are very strenuous, right? So things like burpees, jumping lunges, and they're very good exercises because they do strength and cardiovascular fitness at once. But again, for all of you who do look at YouTube videos and start doing, remember these people are very fit and they've done it for many, many years. So before you attempt this, get your bases going well, and then only attempt exercises like this. So instead of this, you can do things like squats. Now the squat is a very good exercise. We call it the king of all exercises because if you look at it, this is what we call a closed chain exercise. And this exercises nearly every single muscle in your body. When you're doing it, it exercises your glutes, your quads, your calves, your core, right? So all these muscles are working in concert and it gives you a very good strength. So you don't need to jump up and down. You can do this and get a good fitness. Remember, when you do these exercises, do it with proper technique. Now, the important thing with the squat, it's a glute exercise. And you're doing it from your glute, not from your knees. And so when you're doing it, see, the knee does not pass your toe. Right? It's very important. You see people doing it and the knees are going somewhere here, and that's a sure way of getting knee damage. So if you do it, and a good way to start the squat is just keep a chair and go back and sit on the chair and start with it. Right? So remember, it's a glute exercise. And also when you do these exercises, remember your shoulder and hip is in one line. You never arch your back. So start slowly without weights and gradually increase this exercise. The YouTube is an excellent one, resource to go and check these exercises. The next exercise, this is called a lunge. And it's also very good glute exercise. Here also, you can see the knee does not pass the toe and the back is kept straight. And these are all full body strengthening exercises, and they're very good even for knee rehabilitations. This is a step up. Again, you have to do it with proper technique. So these are all very good low impact exercises which give you strength without having to bust your joints. Next is, again, reducing the belly, getting six packs. People do various twisting exercises like crunches, side bends, these Russian twists. Now these rotate the spine and they damage the spine without giving you a huge benefit. Okay, if you're very fit and you're searching for your six-pack, yes, but if you don't have a six-pack, I mean, I advise you not to do it. If you're doing a crunch, not more than 6 inches up, because if you do more, you're going to damage the back. You can see the back is arched here. And even here, the back is in another line. So please avoid this. People do this to lose the fat around the belly. It won't happen also. So you can only get yourself injured. So for the core, instead, do things like planks. The plank is a very good exercise. And here you can see the shoulder and hip are in one line. A rough rule, if your shoulder and hip are in one line, your back is generally maintained with a low doses and you get less back problems. And you can see without bending or extending the spine, you are strengthening all your core muscles when you do this. This exercise is not easy, right? So this is a plank, this is a glute bridge. Then if you want to work your rotation muscles, this is called a Pavlov's press. It works your anti-rotation muscles without rotating the spine. And this is called a bird dog. It's very good for transverse abdominis activation. And swimming, an excellent core exercise where you can get your cardiovascular fitness, swimming freestyle. It's one very good exercise. So, I mean, that's the end of my lecture. So we discussed about how to manage injuries properly. And when you manage injuries, the crux is to diagnose it properly. And it's not just about injecting or doing surgery. It's about doing proper rehab programs and ensuring that the player tissues have healed properly and they don't get injured again. And we talked about injury prevention and the fact that doing a proper injury prevention means doing all your training properly, and it will make you a better athlete and also less prone to injuries. And we talked about exercise prescription and what you should do to be healthy. Thank you.
Yes, thank you very much, Harindu, for that thrilling presentation with Scott's critical bounces, twists and turns, sweeps and lofts. We now have a few questions from our audience. So the first question is about submersing the injured parts in ice baths. Now, there's this question on, I have seen many sports persons using ice baths. Is there a risk of hypothermia there too?
Ice bath is a different thing because that is not totally ice. So water and ice on top. Yes. So ice bath is used as a recovery tool. So they say that after exercise, so you get into the ice bath and it helps with your recovery. So the trainers know the correct time, and I mean, there's no risk of hypothermia because they are coming in. And actually, ice baths have actually saved some players who have got heat shock. Actually, we had a player who developed heat shock and we put in the ice bath and he ended up saving his life. So there's no risk of hypothermia if you do an ice bath properly.
Right. So the second question is, how long newly diagnosed hypertensive patients should wait before they start exercise? I think you have answered this question. Or can they start immediately after being diagnosed of hypertension? Or does it depend on the grade of hypertension?
Not necessarily. I mean, there is this thing saying that people with cardiovascular risk factors are the ones who will benefit the most from exercises, and you shouldn't withhold exercises from them. So as their blood pressure is, I mean, if the blood pressure is not very well controlled, of course, yes. But once it's controlled, yes, they can start. But the thing is to start slowly. So you start with walking 10 minutes and you tell them if you get any symptoms to stop and then gradually increase it. The one thing is avoid heavy weightlifting in people.
The third question is intermittent fasting an effective way to lose weight, or is having 3 meals a day in moderation better?
Okay, it's a very interesting question. So losing weight, the number one thing is calorie deficit.
Right.
So someone can do intermittent fasting and eat about 4,000 calories in the fasting window. Yes. So if you are doing intermittent fasting, it has to be combined with calorie restriction. Right. There are some advantages proven for intermittent fasting, like better blood sugar control and things like that. However, The answer to the question is the calories are the number one thing. The one thing I think with intermittent fasting is when you reduce your eating window to about 8 hours, you will tend to eat less calories.
Right. So there's this question on cryolipolysis. Any comments on cryolipolysis or fat freezing for fat loss?
I'm sorry, I'm not an expert in that, but one thing I want to say is there are no shortcuts.
Yes.
It is diet and combined, 85% diet combined with exercise, and that is the natural way to lose weight, and that's the healthier way.
Right. So
because I think Himanta, I add there, it's not just
yes.
about losing your fat, it's about being healthy. And when you do
Yes.
exercise, we told the amount of changes you get in your heart, and just taking your fat by surgery does not give you that benefit.
Right. So there's this question now. So I have heard that PRP and various other injections through musculoskeletal ultrasound has become quite popular. What's your opinion on that?
Again, I'm a huge believer in proper tissue healing and proper rehab programs. Yes, there is the athlete where we do the steroid injections, where we do the PRPs. However, that is a supportive treatment, and the main thing is these other treatments, and that has to be done as the main one, but you can use these. The problem is athletes always seek for a shortcut. So sometimes these are used more for their placebo effect than anything else, I think.
Right. So there's this again another question from your personal experience. Is vitamin D deficiency commonly detected in amongst the Sri Lankan athletes, and
yes.
does it affect their endurance?
Vitamin D, we were shocked actually. I think when we did the vitamin Ds, even in cricketers, people who spend their time in the sun more than anyone else, their vitamin Ds were low. So we supplement it.
Right.
Whether vitamin D affect endurance is it's a controversial this thing. Endurance is proper training, proper cardiovascular training, and that's the number one thing for endurance.
Yes. So there's another question on creatine. Is creatine a standard supplement in sports medicine?
Okay, creatine is also, it's not a banned substance. So a lot of people use it. So they say the muscle bulk increases with creatine. But again, it's not proven to enhance performance. So the thing is, if anything is proven to enhance performance, what happens? It's banned. So if something is not banned, it does mean that it does not enhance performance. Now this comes to the area of supplements. And when it comes to supplements, the only supplement as a sports doctor I recommend is whey protein. That is, if a player can't get adequate, because normally a player need about 1 to 2 grams per kilogram of protein per day. And that's a huge amount. So if you can't get it from the diet, we supplement whey protein, and that's the only one I recommend. The rest I don't, but it is used by trainers.
Right. So there's this again another question on are there any effective exercises for back pain in elderly and in sciatica? So
yes. I think Himanta, there are many exercises, and you need a good physiotherapist actually. So you start with gentle things like back extensions, some McKenzie exercises, and then progress this on to strengthening. So they are very effective, and you can manage more sciaticas with this.
So about sun exposure versus vitamin D supplementation in athletes, which one is the better, and what is the sun exposure dose for a tropical country, I suppose?
Unfortunately, I think with our skin color, we don't produce that much. So if the levels are low, we go for supplementation straight away.
Right. So now is a sports physician involved in inquiries into banned substances in an athlete? So is a sports medicine a physician a part of this inquiry panel? That's what I think.
Yes, I think one thing is the main aim of a doctor is prevention. So you have to advise athletes and do programs and tell them these substances are banned. But so a lot of our doctors do a lot, and our Sri Lanka Doping Association is very good. They do a lot of work to educate athletes because our athletes can't compete in doping with other athletes because they are They do very advanced doping, and our people will get caught at the slightest this thing. So
Yes.
that is one. And on the panels, inquiry panels are made up of different teams, and it comes down to different boards. So ICC will have their different panel. So that will be mainly up to the Sri Lanka Anti-Doping Association to decide who is on the panel.
Right.
Sports doctor will usually be there. I think Professor Arjuna is the chairperson there. So they have the doctors in the panel.
Right. So I think there's this final question on from a physiotherapist. Now, is physiotherapy in sports medicine different from the standard physiotherapy training that is done? So is there a different training program for physiotherapists in sports medicine?
Now in Sri Lanka, I think we have sports science programs, and there are this thing. But if you take Australia, the physiotherapy, to be a musculoskeletal physiotherapy, they have a 4-year dedicated training for musculoskeletal physiotherapy. So it is programmed only on that. So that's why if you take our cricket team, even we have Australian trained for foreign physiotherapists. So Sri Lanka, I think we do need something like that. But currently, there are only few 1-year programs, things like that.
Right. So I think we have come to the conclusion of the Q&A session.
I would just add one thing for that physiotherapist. I mean, one advice I would give, if you are interested in sports medicine, to work with teams, because that gives you. And if you are looking for a resource book, something like the Bruckner, this Bruckner and Kahn book on sports medicine, which gives excellent advice. So to use those resources till something like that comes. But sports physiotherapy is about experience, because there's not much research in many things, and it's about doing things and learning and doing by yourself to learn.
Yes, right. So thank you, Harindo. And so before we wrap up today's proceedings, I would like to remind our dear audience that the 4th webinar of Collegia in Nutrition Science will be held in the month of July. I would like to thank Dr. Harindo, Prof. Charles, our secretaries of CCP, and for all the assistance provided, and also the AV team of CCP, and of course the attendees. Wish you a pleasant evening. Good night.
Thank you.
Thank you.